Good morning all. So today we have a live in a box case of a possible planned transradial rotablation for an LAD in a 75-year-old gentleman. So this gentleman had CABG, coronary artery bypass surgery, many years ago. Had lima to LAD and rema graft to the obtuse marginal and SVG to PDA. So recently he got admitted in his local hospital in acute ST elevation MI and he was thrombolized for the anterior segment ST elevation MI. Then they did an angiogram in the local hospital which showed that the lima to LAD was completely occluded. There is a vein graft to the distal PDA or the right coronary artery was also occluded. But there's one rema graft to the obtuse marginal was functioning well. The native left mainstem looks okay. The LAD had a significant stenosis at the proximal segment with a heavy calcification with a TIMI3 flow. So this is post thrombolysis. So he had a TIMI3 flow, but it's a very significant stenosis at the proximal part of the LAD with heavy calcification. There's another area of focal stenosis at the LAD at the mid segment. So the idea today is to do an angioplasty of the LAD, proximal LAD, heavily calcified LAD with rotablation and deploy stents. So his LV function was nearly normal after thrombolysis, with his EF of around 55%. There was some regional valve motion abnormalities involving the LAD territory, but otherwise he's healthy. He's a non-diabetic and he is hypertensive and he's on medicines for the blood pressure. So what we are planning to do is a transradial rotablation. So we started with the 7 French slender sheath in the right radial. Essentially the 7 French slender sheath is the outer diameter of the 7 French slender sheath is equivalent to the standard 6 French sheath. So the advantage is you can use a 7 French guiding catheter through the radial artery without needing to expand the artery more than what we should with the 6 French sheath. So that's a special sheath. So this is something which we've been routinely using for higher caliber diameter catheters for angioplasties. And I think most of our PCIs, particularly if it's a chip PCI, we are going with the 7 French slender sheath through the right transradial approach. So the advantage, as you know, that the transradial approach is much more easy for the patient and the recovery rate is also very quick. So with that, I think the idea is to get a XP3 guiding catheter 7 French into the LAD, and we'll take some pictures to see what is the current situation now. Screen. So this is one of our new cath labs in Apollo Main Hospital, which is a biplane lab with we have a dynamic road mapping system, the latest from the Philips system. Yeah. So we'll do some check shots and for road mapping. So let's start with the RA caudal or PA caudal. Okay. And PA cranial, Andrew. And then we'll do a spider afterwards. Yeah. And RA cranial? Yeah. And a spider, maybe, Andrew? Yeah, so you can see the landing zone. The ostium of the LAD also has got some stenosis, but not significant enough. So you can stop. There's a nice landing zone there as well. So we are going with the rotawire directly into the LAD. Having seen the pictures as we described, there is a significant calcific lesion in the proximal LAD, and there is a mid LAD lesion. So anyway, the plan is directly going for rotablation considering the calcium involved. So I've decided to go directly with the rotawire to the LAD. So we are trying to use the rotawire directly into the LAD, and you can see we have the dynamic road map of, you can see the rotawire passing through the tight lesion there. So I think, you know, the rotawire is a 0.009 wire compared to our 0.014, and that's the reason why the manipulation of rotawire has been so difficult. But with the clipper it comes with the rotor wire, we can try and get through without needing for exchange on the microcatheter. But nevertheless, when we are putting stents, we may need to use the normal wires. So we're going to see the cranial view, Andrew. We'll see, make sure we are in the right position. So the advantage of this dynamic roadmap is you can just inject and you can see the roadmap on the top. This is a dynamic visualization of the arteries as the wire goes down, and it gives a lot of benefit in reducing the amount of contrast we use for particularly in patients with coronary artery disease with CKD as well. So I've got my rotor wire all the way down into the distalmost part of the LAD as much as possible, and I think we are ready to go with a 1.5 millimeter rotor bar. So we're going to open a rotor link plus 1.5, and now this gentleman's right coronary artery is occluded, and the graft to the distal PD is also occluded, but nowadays we don't routinely use temporary pacemaker wires for rotablation because most of the times we can get away with doing atropine injections if needed, or a very short duration. So if you reduce your rotablation time to 10 to 15 seconds, the chances of going into significant bradycardia, prolonged bradycardia, is quite low, and therefore we don't need to routinely use temporary wires for rotablation as we used to do in the past. But nevertheless, I do tend to keep atropine ready in case if there is any bradycardia to make sure that the heart rate gets better. So it's always better to check the movement of the bar on the before you get into, and make sure that it smoothly runs. See my hand? So essentially you can do a single operator rotor by rotating the thing, and you need to give a lot of tension on the wire to push the bar. And if there's any doubt, you can always take a cine to make sure there's no looping on the wire just outside the guiding catheter. 1 second. Yeah. So I tend to keep the hub open. Show me the top, Andrew, now. Now we may need to take a little bit more tension because you can see the bar has come up to this level. So here is the bend, so you need more tension on the wire. This needs to come. The left main. Yeah, so even though the guide is not that coaxial, but the bar is already inside into the left main system, so we should be able to but if we can also get the rotor bar inside the LAD as such, because if you think we don't want to damage the circumflex. Yeah, right up and screw it. Now test. Yeah, now it's going listening. See the fluoro. So that's, you can see the guide jumped directly into the left main, which is in the coaxial mode. So let me just, so now we'll take we need to confirm we are in. So now my bar is nicely inside the LAD now, so we can ready to go for. Yeah, it's in the main artery, but I just need to go a little bit more. So what we can do is we can do a dyna glide, and then my second operator can push the wire a little further. So before we do a rotablation. So dyna glide, brother. Okay. That's it, all the way. That's enough, done. So you can see, slow the fluoro. So the rotor has not moved anything, but the wire we managed to get to the distal segment when we are doing a dyna glide, which is 50,000 rotations per minute. So now we can go for a proper rotablation run. You can control here. So what we are doing is we are doing at around 170 RPMs. This is the polishing run, and you can see. So we've done a 170 RPMs with a 1.5 rotabar, 1.5 millimeter rotabar, and I think it's nicely gave way. So we can feel that that's definitely a good channel which created by this rotabar for us to use the balloons. Now we also have noticed that there is no significant bradycardia despite using a 1.5 for at least 4 runs, suggesting that even though he has got a proximal right coronary artery is 100% occluded and the vein graft to the distal RC is also occluded, there is no significant bradycardia when you do the rotablation. So you may avoid using temporary wires in rotablation as you do more of it. But in certain situations where if it's a single surviving artery and if you believe that that can cause compromise on his hemodynamics, it's always better to put a temporary wire. But I think in this situation we decided it's not needed. Thank you so much. Come closer. So you can see the OCT catheter running nicely down after the rotablation. Save the fluid, Andrew. No. Let's see the clearance. Not much, right? No. Because of the lesion in the it's take a little time. Yeah, that's better now. Okay. We've done an OCT run. What the OCT run showed us the amount of calcium and also at the tightest part of the LAD where we did the rotablation, how the calcium has been cracked by the rotablations, and the luminal gain after rotablation was seen. And the second lesion, which was around 20 millimeter below the first lesion, also had a calcification, and the rotablation was done there as well. It has increased the acute luminal gain after rotablation. So we did a reference diameter of the vessels and we were deciding the size and length of the stent. So what we realized is the proximal most part of the artery is around 3.9 or 4 millimeter, and the distal most part of the reference vessel is around 3 millimeters. So we need to choose a stent where we can put one stent and we can optimize the proximal segment. So we decided we'll balloon to the 3 balloon at the tight portions, and then we'll use a 3.5 by 48 millimeter length stent covering both the lesions in one go, and then we'll optimize with a 4 balloon or a 3.75 balloon at the top of the topmost portion of the stent. 6, 8, 10, 12, 14. So this is a 3 millimeter balloon at 14 atmospheres. Okay. It's going now. Test now.
Come back.
Test.
The
test.
second door.
Test. Yeah, somewhere there. Okay, we'll take a picture and just confirm and then we'll do.
Just a place.
Yeah. Just a short 2 ml. Yeah, okay, but my guide is out, so that's probably why. Yeah, just go up there then. 2, 4, 6, 8, not very high this time. 10. So this is a 3 millimeter at 10 atmosphere at the distal part of the lesion. Go up again, just make sure. This time you go up to 12, 14. So this is a segment which is not much disease, but we want to make sure that we expand nicely there. 16. 18. Down. Just gentle breathe in, sir. Okay, breathe normally. So you can see that the stent is, yeah, I'm just pulling back. Test. Yeah, more. Okay, we'll take a picture and see whether. Back, yeah, come back, yeah, that's fine. Okay. Take a cine there. Yeah, that's fine. Come back to cranial. We'll see. Make sure we are covered in the cranial.
Okay.
There's a place.
Just below that.
Caudal, sorry, caudal. Wait, caudal path to peru. Ready? Injection proper. Yeah, that should be okay. Yeah, okay. Yeah, come to cranial and she'll deploy there. Yeah,
You're good.
yeah, go.
Go to 9.
Go, slowly go. 8, 6,
Number 2,
4,
4, 6. I'm waiting at 6 now.
yeah,
At
8,
6,
8.
6, 8.
That's it, keep it at 8 because distally I don't want to go
Leave it
to. So 3.5 you see. We definitely need a 4 to expand at the top.
8 la irukku. Distally down.
Yeah, down. So we deployed a 3.5 by 48 Zion's stent just above distal to the second lesion, but there is some atheroma distal to the stent, but that is expected that there is around 30 to 40% atheroma, which is not seen anything different from before. But the stent is fully expanded at the second half of the stent is fully expanded, but the proximal half of the stent needs better expansion. We purposely put the stent at 3.5 at 8 atmospheres, so giving it 3.3 millimeter in diameter, whereas we know from the OCT images that the proximal part of the LAD is around 3.8 to 4 millimeter in diameter. So therefore we are using a 4 millimeter balloon to optimize the proximal most part of the stent. So when we are putting a stent at a low pressure, particularly when these kind of long stents, which is a 48 millimeter, you know that there is a discrepancy in the proximal reference diameter and the distal reference diameter. When we are selecting a size that is much lower than the proximal reference diameter and you deploy the stent at a low pressure, there are two important things you need to understand: that you should never lose a wire position, because the proximal most part of the stent will be overhanging in the coronary artery without touching the endothelium, and that can, if you're losing the wire position, you may have a difficulty getting the wire, and you may end up doing behind the stent struts. Second thing is, when you are using balloons to post dilate, make sure the balloons run smoothly, because there may be some bias, wire bias in the artery, which could cause damage to the stent. So we may need another wire as a buddy wire.
Yeah.
It's going through somewhere. Oh, that's another branch.
If you want to
You may go to caudal, Andrew. Yeah. So I went to the loop, so you can use on this wire as well. I think the wire bias is causing. We can do. Okay, we need to demarcate the wires. Okay.
Wait. Which way?
So
you want
this
to
is
go?
the one I'm going on this one. Okay, so I'm going to hold this.
Put this.
Yeah, you put a marker to a torquer on that. Okay, same problem. Yeah, that's gone now.
Yeah,
Okay,
yes,
so we need to remove the other wire.
Why?
Yeah, because we can't do both.
Can pull the wire down.
It's okay. Which one
Hold
is?
this.
Yeah.
This I'm pulling. And this needs to be pulled.
Okay. So we are expanding with the 4 millimeter NC balloon at 10 atmosphere at the mid segment. But as we come back, I may go for a higher pressure. 10, right? 12 and down. So that's the severe calcified part of the artery which is stented. So we come back more. Yeah, you can see the 10, 12, easy. You can see the expansion. You can see the under deployed stent to the proximal most part. Go up to 14, 16. Yeah, keep it at 16. So you can see the nice expansion there. Right. I think that should be okay, right? Ready for a picture of it? I'll take one picture here to make sure there's no dissection in the proximal most part of the LAD. But because it's a bulky balloon, we need a bigger and stronger injection. Yeah. So clearly you can see the step up or the proximal most part of the stent. and there is a step down at the distalmost part, which is nicely seen in this view. So we're going to go for an OCT run. So we need. So when I try to push the 4 millimeter balloon, there is some difficulty in passing the ostium of the stent, and as I said, it's better not to manipulate the balloon too hard at the proximal aspect when the stent is under deployed. So what I did is I passed another wire, because the most common reasons why the balloon is not crossing through is because of the wire bias, and passing another wire with a looped matter. So I know that it's going in the true lumen, then I pass the balloon on that particular wire, and it made this passage so easily now. So we think we have done a 4 millimeter post dilatation, and we think we will be able to get a good result with this. So we will confirm that by an OCT before we finish our case. If there is any discrepancy, or if there is anything we are not happy on the OCT, we may go back with the further ballooning of the LAD. Okay, yeah, some of that. Okay, yeah, ready?
Here.
Okay, 20 minutes. No, we are okay, I think.
354.
Yeah, that's clearance is better. 1 second. Okay, when you're ready, you tell me.
Yes, sir. We are done.
Constant pressure. I just first. That is the main. Go in slowly. Excellent. That's good. That looks okay to me. Good. And expansion, you're getting 9.7, 133, 1%, and now slowly go in. Yeah.
Very good.
The position is good. And
Yeah.
expansion if you see,
Yeah.
this is the reason.
And just show me the distal most part before, and then we can get him off. Then we can analyze. Distal most, there's no dejection of the edge. Fine. Okay. Good. Ready? Okay. Radha?
I'm ready.
Okay. Wait for the couple of minutes. Now inject. Yeah, all is good. And one more caudal, I think, isn't it? That stray RA caudal or something.
What is the LED ostium size?
No, that's good. I'll show you. 7, 6 or 7. Ready, Andrew?
Yes, sir.
And last RA cranial. Yeah, it won't come. Okay, don't worry. Thalai mattu left side la thiruppi vechirunga sir. Just turn your ready? Last picture. Excellent. Okay, sir. So this is the 7 French sister. This is the 7 French slender sheath. We know that we can do most of the cases with the 7 French slender sheath, even chip PCIs. So we demonstrated that we could get a rotablation of 1.5 millimeter bar rotablation of the LAD through a radial transradial approach. So now I'm going to put a TR band to confirm that there is hemodynamics is hemostasis is achieved by doing this. Sorry, now you're going to put a TR band to make sure that the hemostasis is achieved at the radial side. Yes, I'll show you. So this is the TR band we routinely put for the transradial cases, particularly because we don't want to lose the radial artery, and so this yeah, ready? Well, that's it. Okay, sir. Okay. So this is the pre-PCI angiographic images of the left system. As you can see, the left main is normal. The LAD has got a very tight lesion, and you can also see a diagonal coming, which is the grafted diagonal, and we know from the previous angiographic images that the graft to the diagonal, the Rima graft to the diagonal, was flowing normally, and because of the injections you can also seeing some backfilling, as we see sometimes with the retrograde flow through the diagonal as well. So what in the cranial view, you can see the tight lesion of the LAD, and the mid segment has also got a very tight calcific lesion. And this is an RAO cranial view showing the same thing. So now I'm going to show you the images of post PCI images. So this is the post PCI images of the caudal view. You can see the LAD stent is fully expanded, but you can see the diagonal branch which is coming at that segment has not seen now because the antegrade flow through the graft has completely taken over the diagonal. So the diagonal is not seen now, and that is the reason why we are not seeing the backfilling of the diagonal through the proximal most part of the LAD, because now we have a good brisk flow in the LAD. The diagonal flow is completely reduced and the graft has taken over the diagonal flow. So that is what, again, in the RAO cranial view you can't see the diagonal at all now, because the graft is supplying the diagonal in a brisk way, and therefore the proximal LAD segment, because we opened up nicely and there is a brisk TIMI 3 flow in the LAD, the diagonal is not back, the diagonal graft is not backfilling. And you can see the left main is looking normal, and there is no evidence of any dissection at the ostium of the left main. Thank you.